Good evening, everyone. I am Dr. Vaishnavi Pradhan from the team of Voice of Healthcare. I warmly welcome you all to National Aplastic Anemia Forum, a clinician-focused virtual panel discussion series supported by BSV Mankind. The topic of today's session is aplastic anemia, pharmacological management, and non-pharmacological management. The management landscape of aplastic anemia continues to evolve with advances not only in pharmacological therapy but also in non pharmacological therapies. Despite these advances, clinicians continue to face challenges related to patient selection, sequencing of therapies, response assessment, and long term disease control. Today's discussion aims to provide a holistic, practical overview of both pharmacological and non pharmacological management strategies grounded in real world clinical experience and evidence based practice. We are privileged to be joined by a distinguished panel of experts, Dr. A.K. Ganju, Director and Clinical Hematologist, Ganju Hematology Clinic and Hospital, Nagpur. Thank you for joining, sir.
Thank you.
Dr. Amit Kumar, Senior Consultant, Medical Oncology, Hemato-oncology and Bone Marrow Transplant, Jaiprabha Medanta Superspeciality Hospital, Patna. Thank you for joining, sir.
Yeah, thank you.
Dr. Nivedita Dhingra, Director and Head, Adult and Pediatric Hematology, Hemato-oncology and Bone Marrow Transplant, Yashoda Medicity. Thank you for joining, ma'am.
Thank you for having me.
Dr. Vikas Goyal, clinical hematologist and bone marrow transplant physician, Sanjeevani Cancer Center Hospital. Welcome to the session, sir.
Thank you.
Dr. Gopinath, consultant hemato-oncology and bone marrow transplant, MGM Cancer Institute, Chennai. Welcome to the session, sir.
Thank you.
We sincerely thank you all panelists for their participation and valuable time for today's session. With that, I would now like to hand over the session to Dr. A.K. Ganju, who will be moderating today's session. Thank you, and over to you, Dr. Ganju.
Thank you, Dr. Vaishnavi. Well, today I am the moderator of this webinar, wherein we are going to discuss something about aplastic anemia. We'll start from zero and we'll try to reach the climax in the treatment of aplastic anemia. As we all know, this aplastic anemia has been there for centuries, and the treatment, in fact, started just 50 years ago. And the first patient who got treated was with the bone marrow transplant, but to the surprise, it was basically the autologous bone marrow which got regenerated. And that was the time when people started understanding that immunosuppression is the treatment of aplastic anemia. Well, since then we have traveled a lot, and we know if you see the epidemiology, at least 2 to 3 patients per million population is the rate, and in fact it's more in children, and in India, in the Western, it's actually more towards our countries than the Western world. And since we have been seeing these patients day in and day out, in fact, at least I see 1 or 2 aplastic anemia per week. So it's not very uncommon for us, for the hematologist, to see this, and therefore we need to be, well updated. And currently, fortunately, we have good drugs. These drugs are available, and these are made available for each and every patient by the government. All those the programs which are there. And hence, it's prudent for us to go into the nitty-gritty of how we manage aplastic anemia. So first, I think we'll start with the diagnosis and how do we diagnose aplastic anemia. I request Dr. Nivedita Dhingra to just elaborate how should we make a diagnosis, and if we can discuss something about the differential diagnosis, I think I would be great. So, Dr.
Thank
Nivedita.
you for the question. Thank you for the question, sir. So firstly, I think what is very important when we are dealing with a patient of pancytopenia where we are suspecting aplastic anemia is to do a thorough history and physical examination. We should also focus, if it's a child, we should look for any stigmata of inherited bone marrow failure syndromes. We should definitely go ahead and take a detailed family history of any blood disorders, any malignancies, even things like pulmonary fibrosis, cirrhosis. They could all indicate an underlying inherited bone marrow failure syndrome. And any previous history of any kind of hepatitis, viral infection, drug intake, alternative drug intake, any autoimmune illnesses. So, a detailed history and physical examination, we may have any advanced diagnostics, therapeutics, but the core medical principles should be followed. Then, when we order a battery of tests for a hematologist, always the battery of tests begins with a good peripheral smear examination. We need a complete blood count with the differentials because we need the exact neutrophil count to classify aplastic anemia and identify the severity of the disease, whether it is severe, whether it is very severe. A reticulocyte count must be done because, again, it's important. Apart from that, viral markers, a bone marrow aspiration, and a lot of times what happens is that patients come from other centers and only an aspirate has been performed, but a biopsy has not been performed. So, doing a bone marrow biopsy is very, very important with a good core where we can evaluate the bone marrow cellularity properly. So, bone marrow aspiration and biopsy is absolutely essential, of course, to make a diagnosis of aplastic anemia. A chromosomal breakage study should be done up to the age of maybe even 30 to rule out underlying Fanconi anemia. And testing for PNH must be done in all patients to see if there is an associated PNH clone present or not present. The value of doing additional tests, additional viral serologies like EBV, I'm not sure. I'm not doing routinely in my practice. Autoimmune testing, if there are no stigmata, I'm not routinely doing ANA. So these are some of the tests that I think we do routinely when we encounter a case of aplastic anemia. And others can add if I've missed something.
Yeah, thank you. Thank you. Actually, in fact, it's a once you see the patient and you examine with his clinical symptoms and you do CBC, you're almost sure about your diagnosis most of the time. It's just you need confirmation, and then finally you would like to segregate, whether it's a genetic or a non-genetic, and all the battery of tests that goes on and on. So at this moment, when you have diagnosed a patient of aplastic anemia and you've seen the bone marrow aspirate findings of
Somehow I'm
bone
not
marrow,
able to hear Dr. Ganju sir. Others'
yes,
voice are coming, but from sir's voice is not coming.
can you hear me now?
So
Hello.
you are very audible to us, actually. To me, you are
Yeah,
very audible. I don't know about the other panelists.
your voice is also coming clear, ma'am. So you're audible, but sir's voice is somehow not coming. I just don't know. I'm not hearing anything from his end.
So
It is
everybody,
like that.
can you hear?
Okay.
All of you are hearing me
Okay.
what I
I
say?
think we can have a
Now
show
we
of
will
I
hear.
can
hands.
hear. I can hear. Yeah, I can
Okay.
Okay.
hear.
And what about Dr.
Okay.
Gopinath?
I
Can you
can
hear?
hear you also, sir, but not Dr.
Anyway,
Ganju sir
I'll have to shout
somehow.
then. Okay, fine.
Okay. I'll try to rejoin
See,
again then.
uh,
Okay.
so at this moment, once we have made the diagnosis of aplastic anemia, in fact, we would like to differentiate myelodysplasia, hypoplastic MDS. And these two conditions are very important for us because that will change our plan of treatment. So, Dr. Amit, can you discuss something about how you differentiate aplastic anemia versus hypoplastic MDS? I think your internet is not good, Dr. Amit. You're not moving at all. So, Dr. Gopinath, you can take this question. You can take this question: how to differentiate myelodysplasia, hypoplastic MDS, and aplastic anemia? Are there any tests, clinical as well as the lab? So, just give us the brief on this.
Yeah, I think Sir has touched upon the important thing. In fact, it is the core interesting topic of mine. This becomes more relevant when we deal middle-aged aplastics, where we have a proper discriminate, where we have a certain confusions between drawing a line between aplastic and hypoplastic MDS. So clinically, we have a scoring system which is called as HMDS scoring system, where we can put up the 4-5 differential points depending upon the marrow microenvironment. If there are more inflammatory microenvironment, then it favors more of an aplastic anemia. Whereas if you don't have an inflammatory microenvironment, a lot of plasma cells, many times in aplastics we see a lot of lymphocytes and plasma cells, whereas in MDS patients we don't get to see that more. And second is the CD34. Based on the CD34 and the fibrosis, again, there is a grading system that is available as per the BGH guideline. So that we can make use of it. So to differentiate between hypoplastic MDS versus aplastic anemia. And third is maybe I can just come tell one of the case that I came across in my practice where I had a severe confusion between aplastic anemia and hypoplastic MDS. So this was a 53-year-old gentleman who came to me with pancytopenia. He was working in a fertilizer industry. So, history-wise, the only significant history that I had with this patient was a family history of breast cancer. So, I did a marrow. Marrow was looking full of hypoplasia, but not much of an inflammatory microenvironment. So, it is, but this guy had some kind of Palmer, he had some hypothenar, flat hypothenar eminence, and he had some kind of a dysmorphic thumb. It was when I just called up the son to work up as a donor for transplant, the son's hand was frankly hypoplastic. So actually, when he did a chromosomal breakage for the patient in question, he had chromosomal breakage positive at a 53-year-old, at the age of 53 years. So I also sent an exome sequencing, considering this could be some late manifestation of inherited bone marrow failure syndrome. But the surprisingly, the IBMFS gene panel came out to be negative. It was reported as negative test. So then I didn't. I mean, I had a strong suspicion because the son was looking too much of a syndromic hand. So what I did is I got the genomic data from MedGenome. I rechecked it with one of the geneticists, clinical geneticists over here, and he identified ERCC6L2 variant, which is known to cause bone marrow failure in late age and which can also transform to MDS and AM. So I think this case taught me a lot. Had I just thought him as an age-related MDS and I could have transplanted him, I would have actually given a MAC conditioning and I would have lost the patient. So this is something that I learned from the patient, that even at later ages, patients can have IBMS manifesting as MDS. I think thorough check on the marrow microenvironment, thorough check on the chromosomal breakage. I'm at least at this point of time, if I even have subtle clinical stigmata in this patient, actually the family members gave me the clue. One had one with the history of breast cancer, and the son's dysmorphism gave me the clue to diagnose an IBMFS. So I think getting a good thorough and family history of blood cancers. I am not, discouraging doing chromosomal breakage even across ages if we have such certain features like this. And I think we all should look at doing flow fish for telomere length. I think only few research centers do it. I
It's
think
not easily available.
it is not easily available. Yeah, I think that is one thing that is need to be considered. And exome sequencing, even if they give negative, I think we should re-verify the data by ourselves with the help of our
I
clinical
think most
genetics,
of us are doing NGS now, regardless of
regardless.
anything.
Yeah. And the main thing is about the likely pathogenic variants and variants of uncertain significance, it's a discussion in itself. So I think this is what I wanted to add.
Yeah, thank you, Dr. Gopinath. I think we'll discuss something about how we classify these aplastic anemias, because I think that also determines our plan of treatment. So, Dr. Goyal, you can discuss about the classifying aplastic anemia, and with that, you can discuss about the pathobiology, mostly the autoimmune part.
So, depending on the severity, sir, we can classify aplastic anemia into three categories. One is severe, one is very severe, and one is moderate severe aplastic anemia. So, severe, we say when the bone marrow solubility is less than 25% and ANC is less than 500, absolute reticulocyte count is less than 40,000, and platelet counts are less than 20,000. And when the NC count is less than 200, along with whatever I said, then patient falls into very severe aplastic anemia. And if the patient doesn't fall into both the category, we call it non-severe aplastic anemia. So depending on the severity and the severity of hyposolubility, we classify the disease into the three categories. So this is the way to classify the
Yeah,
aplastic
about
anemia.
the autoimmune part, the pathobiology, especially the immune.
Uh, Sir, it may be inherited like congenital or it may be acquired. Most of the patients are having idiopathic aplastic anemia that is acquired and immune mediated. But some of the patients, especially children and younger adults, they might have inherited bone marrow failure syndrome component. So depending on the etiology, we can also classify the patient into these categories.
So, so once we make a diagnosis of aplastic anemia, how do we counsel the patient regarding its management plan? So, can Dr. Amit is there? No. Okay, Dr. Nivedita, you can discuss out how you counsel and what is the scope of management in this aplastic anemia once you have already classified very, very severe or severe aplastic anemia.
So, sir, the first thing to take, there are a couple of things that we take into consideration while we are managing aplastic anemia. One is, of course, the age of the patient. So, traditionally, the cutoff for transplant eligibility has been 40 years. But now I think for a fit patient, we can be a little flexible with that and consider a transplant for an older patient as well. And the second most important, or rather equally important, would be the severity of the illness. So, for non severe forms, mostly we rely on medical management. But for severe and particularly the very severe forms, we have to consider more definitive treatment options, of which in younger patients, we do counsel for a bone marrow transplant from the best available donor. So now the current guidelines, they recommend that a matched sibling donor and mud donor can be used for younger patients up to 20. We can even consider older if the patient has a fully matched donor and is fit. And if the patient does not have a fully matched donor available, then the options for us are that we go with medical management with immunosuppressive therapy, which comprises of cyclosporin, Eltrombopag, and ATG. Or there is also an option which we can explore is that we can consider a haploidentical transplant. Although, as per standard guidelines, it's not recommended upfront. But I think in our country, where the cost of ATG infusions is equally high, the time to response after ATG, it takes 3 to 6 months. And in that period, also, the patient needs supportive care, a central line, SDP infusions. So I think a fair discussion with the family, discussing the pros and cons of all treatment options, has to be there. This is the definitive management, but equally important is good supportive care. We have to guide them regarding transfusions. And for patients who come from periphery, directed donations have to be avoided. This has to be stressed because that is a practice sometimes that happens. Not everybody has access to irradiated blood products. As far as possible, safe and irradiated blood products, especially for transplant eligible candidates, is something that we have to see because funds might not be readily available. So more often than not, we do start treatment with cyclosporin and Eltrombopag on an OPD basis while we are awaiting and searching for the best available donor. So these options are laid on the table. And like Dr. Gopinath mentioned, I always believe that a thorough history, physical examination, and family history, because we have had an instance where we had a patient with pancytopenia and a hypocellular marrow, but she had a sibling with AML who died during induction. When full intensity induction was given, she had another sibling who had some edema of the lower limb and some mild cytopenias, and the whole family turned out to be GATA2 mutated. They had Emberger syndrome. So in them, we went for a matched unrelated donor transplant. So very comprehensive approach, right from history, physical, even for deciding management. That becomes the crux, and other panelists can chip in
Thank you.
because you do tend to forget some important points while discussing.
Yeah, thank you, Nivedita. Basically, you have to see two things. One is the age, and the other one is if he has a sibling who is fully matched. So these two things have to be seen, and that will determine our line of action. Maybe if patient is more than 40 years, you can think of immunosuppression. If patient is less than 40, then you think of the transplant. But if he doesn't have HLA matched, then you have to, search for the other methods, the other donors. So one can see for the unrelated matched donors. Well, once we have planned our treatment, for example, this patient is more than 40 years of age, he's around 60 and has developed severe aplastic anemia and needs a treatment. Now he comes to us. So what are the challenges which are basically we facing when we counsel these patients for immunosuppression? Dr. Gominathan?
Yeah. So I think I kind of answer this question, particularly more than 40 years immunosuppressive therapy. So basically, we have to tell them that even if we do ATG triple immunosuppression, the first challenge comes there is the adequate blood transfusion support, and even after we discharge from the hospital, they should be able to get that irradiated blood transfusion support. So many patients may be traveling from periphery to the city center for getting this therapies done. So continuous and ready-made access to irradiated blood transfusion products is one thing, and second thing is the infection prophylaxis. So till 3 months, at least when they are within our radar, we kind of take them again, prevent them against all the possible viral or fungal or whatsoever bacterial infection. But they just skip out from our radar from the third or fourth month. So unless the safe count recovery is achieved, then I think still that the danger zone for immunosuppressive supportive care provides. And third is ensuring the compliance. So, I mean, even the moment we say it is cyclosporin or tacrolimus, particularly in elderly, you may come across people having easier creatinine rearrangement, press, and sometimes even with Eltrombopag, we have had some cholestatic hepatitis going on for quite some time. In between we have to stop, switch over to romiplastim, and so these are some of the common clinical challenges that we face in clinical practice. Rest, I think it's more patient-oriented and individualized support. I think this can.
Thank you. Thank you, Dr. Gopinathan. So we plan for example, now, if we plan this patient for cyclosporin and ATG, the results are around 40-50%. That's the maximum you can get it. And considering the pathobiology, where we have understood that it's the stem cell defect, so why not to improve those stem cell defect by using thrombopoietin agonist? So with this, the results have increased. In fact, in the Western world, they are around 90%, but then we haven't been able to get to those results. Maybe maximum we would be around 70-80%. So anyway, now once we have made a diagnosis and we have planned for the treatment, we have already counseled. Now this patient gets admitted in our hospital. So can you discuss how you manage these patients and what, especially the ATG which you are going to give? How do you manage? How do you give this ATG? What is the best method of giving so that the least, anaphylactic reactions, they are taken care? So Dr. Goel can discuss about this.
Yes, sir. So once we have decided and the patient, after counseling, patient has agreed that he is going to receive ATG therapy, we need to admit the patient, preferably in isolation ward because they are immunosuppressed, so chances of getting infection is more. And usually we can get hypersensitivity reaction. Patient can have serum sickness like syndrome. So before giving ATG each day, we first have to give prednisolone. In my center, I give methylprednisolone before giving ATG. Then also I have to I give a test dose so that we know whether the patient is developing any reaction to it or not. And then if the patient has not developed any reaction to it, then according to the doses, we transfuse over 4 to 5 hours. And central line is important because it is basic end. So we also have to make sure that patient is having central line for the infusion. And during the infusion, we have to monitor the patient. We have to regularly check the vitals of the patient, whether patient is developing any reaction to it or not. And if the patient doesn't develop any reaction, we can complete the 1 day therapy in 4 to 5 hours. And each day we transpose HDP also because ATG also causes temporary thrombocytopenia. Patient may develop leukopenia. So each day we transpose HDP prior to giving the ATG.
Yeah, Doctor.
So
Yeah,
this is
thank you, Doctor.
yeah.
Dr. Amit, can you elaborate on how you give the
So I will
ATG
more,
while
yes, sir.
patient is admitted? Yeah, you put him in
So it's a
ICU
more,
or you give him in a single
no,
room?
I give
What's
in the
your
basically it's in the single room or even in the ward. So we have got that setting that the patients are slightly isolated in the ward also, and we are giving in the same way. They are self-served with all the pre-medications and with a close monitoring. So we have got a monitors place in the ward, and we can manage there only this patient. And regarding the reactions, so we, initially that's the close monitoring on the reactions, which is the most important thing which we do at this time frame. And after 4 days of ATG, the only thing is the platelets. That is, the cutoff for the platelet, we keep it higher in the initial days for these patients. So we just give them, try to maintain the SDP, arrange the STPs upfront. So the most important thing is the day one, we counsel the patient regarding the blood products and the requirement of the SDPs, and that is the thing which we have to be maintaining it for the next. So it's required for a long time, and these patients are, at the time we give ATG, so most people are.
Okay, we have lost him again.
Not like
Yeah,
that. Yeah. So
yes,
in
yes.
our center, the
Do you all give you do a routine sensitivity test before you start ATG? What is the method you do? Do you dilute the ATG first, put in 500 ml normal saline, give for some time, wait for the reactions? So
That is how I,
what is
that is how I
how
do,
do you
sir.
do that?
Yeah, one vial and 500 ml NS. Run it at
Same.
5 ml. Run it at 5 ml per hour. Maybe for child they have a different dilution. We can do it at 0.4 ml per kg per hour is what they say. So 5 ml per hour is we run, and then 510. Once we are safely reached up to 200 ml, then we add maximum 3 vials. We can 3 to 4 vials. We add in 1 pint of NS.
Yeah, Dr. Vikas, how do you do that? You have
So
any
usually,
difference?
what so in KEM, sir, we used to take out 1 ml of ATG, and we put it into the 100 ml NS, and then we slowly give up to the 1 hour. Very slow we have to give. And if the patient doesn't develop any reaction, then we infuse rest of the ATG as per the protocol.
Okay, we also do the same way. We give initially we give small dose in. Actually, we will give small dose in 500 ml normal saline. Wait for any reactions to occur. If it doesn't, then we put in next bottle. We'll put all the vials for 24 hours. That's how for 18 hours, 16 to 18 hours. So that's how we do it. And which ATG do you use? You use horse ATG or rabbit ATG? And if horse, why? And why not rabbit?
So
Yes, Dr. Nivedita, you can add.
So we use horse ATG for upfront management of aplastic anemia because there's data to suggest that horse ATG has worked better in the upfront management. Although if there is a recurrence after the primary treatment, which can happen in a few patients, that the disease after an initial period of response, it may come back or it may not respond even after 6 to 9 months. In that, there is data for rabbit ATG. But for upfront management, we use horse ATG. And now Thymogam is the only available product which we use.
Yeah. The rabbit ATG gives, it gives profound immunosuppression, and despite that, you don't have good results. So therefore, we are using the horse ATG, and the results which are there for first line treatment, they're the best. 40-50% is 20-30% within 3 months is the complete remission rate with the horse ATG, as opposed to the rabbit ATG, which is very little. Anyway, but in the lab setting, rabbit ATG is okay. Now, the generic ATG was available in this country, especially after the COVID era. I don't think we had used the generic before the COVID time. So, any experience of using and comparing that with ADGAM, the innovative one? Is there any difference? There have been many studies which are now available from this country, and they show the equivalent results. In fact, they have seen that you can use ADGAM at 25 milligram per kg versus 40 milligram of Thymogam. That's the Chandigarh study is available for us. So what's your experience of using Thymogam and the results thereof? Yeah, Dr. Gopinathan?
sir, I mean, AdGam, I would say I would use only in few. Thymogam is my predominant experience. I can see, I can maybe quote a marginal difference of 10 to 15% between both at the same dose. Rest, I think predominantly my experience is only with thymogam.
Dr. Vikas Goel?
Sir, I also, in most of the patient, I have used thymogam only, and adgam very few patient. And I don't think there is much difference if we see the efficacy. Maybe hardly 5 to 10%. Maybe the original one is more efficacious, 5 to 10%, but not more than that.
Great. Dr. Amit, what's your
So,
experience?
so I have experience only with thymogam, so I cannot say. So I have a good experience. The patient is in remission with that, definitely.
We have used the first AdGam in 1989 when it was available as Press Immune. So that time it was not available in this country. It used to come from black market from where we used to procure. And now we have our own generic thymogam, much cheaper than the AdGam. And AdGam presently is not available. I don't know whether it's available. It's not available. They say they had, all those factories, they started making vaccines. So they shifted to that. Anyway, maybe we get it sooner or later. So once we have understood that the thymogam has to be given like this, what is the duration you are going to infuse? I think there is some discrepancy. We would like to know which is the optimum duration of infusion. Dr. Nivedita, Dr.
So, sir,
Gopinathan.
our
Yes.
practice first day, a lot of times the infusion gets really prolonged because there are reactions, there is interruption. But I think second day onwards, we try to infuse it over 8 hours.
I agree
Everybody
with
has
this.
8 hours.
Almost the same answer. I mean, first day it usually takes 12 hours. Sometimes it has taken 14, 15 to 18 hours also, particularly with larger doses. But from second day, usually somewhere between 12, before, less than 12 hours is what we usually complete the infusion.
So it's great. So we have understood that even thymogam is equivalent in the potency, and we all have used in last 5 years, and the results are really good. The
Maybe one
second
one
component.
question can I ask, sir? So particularly if we kind of decide to go ahead with ATG in the elderly, say for example, around 50, 60 years, have someone experienced acute cardiogenic events post ATG infusion on day 3, day 4? Acute cardiac events post ATG infusion.
No, we have no experience
No.
of that.
So,
So actually I
do you
had,
have a
yeah. So
okay?
I initially thought it was so I had one patient experience like this, that on day 4 that lady went in for an acute myocardial infarction. So initially I was thinking whether it is kind of any fluid overload related, but then I just came across some literature saying acute cardiac events can get precipitated post horse ATG infusion, and that is when some protocols, some centers came up with the low dose protocol, like 20 milligram per kg instead of 40 milligram per kg. This is not for the younger age group, but for the elder age group, somewhere between 50 to 60 years. So that is when I wanted to just take the experience of the forum. Like, have they experienced something like this, or
Well, thank you. Any other significant adverse event we have seen? Anyone can speak that?
So
Any
press can
specific
happen
adverse event?
during ATG. Diffuse alveolar hemorrhage can happen. So we have seen diffuse alveolar hemorrhage, which was difficult to discern that whether it was due to refractory thrombocytopenia or attributed to ATG. So these are two unique events. Press, we especially saw in a patient who had a slightly higher PNH. Hemolysis is something that can happen, that can be precipitated by ATG. And one thing now that we are using Eltrombopag with ATG triple drug regimen. So there is data, and we've had one patient where the use of Eltrombopag later on, especially in patients with PNH, they can evolve into MDS with monosomy 7. So we've had one patient who initially went into complete remission with ATG plus cyclosporin plus Eltrombopag, but came back 2 years later with pancytopenia, and that time he was MDS with monosomy 7, and he had to undergo a transplant. So
Any
that's a
any
Anybody
evidence
has
of
seen, sir,
clonal
clonal? Yeah, sorry, sir.
any
I
evidence
am
of
asking.
Evolution with ATG. See, we know that even aplastic anemia can clonally, progress. So it would be very difficult to say whether this is because of ATG or not. But then, is there any literature available where ATG has caused clonal evolution?
Rather, I would. It's a natural disease process of the aplastic anemia. I would
Yeah,
rather say than ATG. But
right.
Eltrombopag, this TPO agonist, there is again a theoretical risk with clonal
We'll
evolution.
discuss
But
that. We'll discuss that.
yeah.
We'll discuss it separately.
So I think so. The
Well,
data suggests around 4% chances of clonal evolution are there with the use of ATG. The initial role of doing an NGS or whole exome sequencing surely helps us in few patients where we may suspect that these patients may be on high risk later on. Uh, I think so.
patients who have been treated with cyclosporin also can progress clonally, 3, 4, 5%. That's the natural history, as Dr. Gopinath has already said, that there is a natural history of development of clonality. Well, after this, I think second component of our ACE therapy is the cyclosporin. So, how you give cyclosporin? What is the dose? At what time you give? And any pharmacokinetic changes you would like to change, or I mean, the time and before food, after food, dose. Does it matter in aplastic anemia? Yeah, Dr. Nivedita.
Usually, we give cyclosporin in a dose of 5 milligram per kg per day in two divided doses. And we encourage the patients to take it at the same time because we would like to monitor the trough levels. So they have to maintain a proper disciplined schedule of taking the drug. In case it's a kid who's taking the syrup, we have to guide them properly that it has to be taken in a glass container mixed with juice, and then again they have to put some juice. The syringes should not be flushed. So a detailed thorough instruction of the drug, and then explaining the side effects pertaining to the drug, whether it can lead to a higher BP. Hirsutism is something which is very distressing to patients. So they need to be aware that it's related to the drug, the gum hypertrophy. So all these instructions have to be given in detail. And yes, trough levels should be monitored. Ideally, they should be maintained between 200 to 400 when we are doing medical management for aplastic anemia. So broadly, we think this is the counseling that we do for cyclosporin.
You start that on day one of ATG, cyclosporin.
So earlier we were starting it on day 14. We were giving steroids till 14 days because the risk of serum sickness, and then we used to start on day 14. But now with the new trial with the Eltrombopag study, we are giving it from day plus one only.
Right.
Sometimes, although I
So
do interrupt if there is some hepatic toxicity with ATG also happening, and then I push it back a little. But as per protocol, now it is from day plus one. Changed practice a little bit.
okay, with that we come to the most important part of this because that has really improved the results of aplastic anemia use of Eltrombopag. So this Eltrombopag, we know that it's a CMPL agonist. It stimulates, activates the CMPL receptors which are there on hematopoietic stem cells, and that's why, though we thought initially that it works only for increasing the platelet count, it does help the pluripotent hematopoietic stem cell to grow. And now, if you see that in these aplastic anemia, their levels are very high. Even thrombopoietin level is very high, and yet the doses which we are using for aplastic anemia, it does help. Initially they used 50 milligram a day, but there was not much of difference, and the difference was seen only when 150 milligram that was started. For us in India, it's not Southeast Asia, and therefore our doses and Western doses seem to be okay. So let's hear something about the Eltrombopag, how how it has really improved the results of the cyclosporin ATG together when we use it from day one onwards. Dr. Vikas.
So the triple therapy has been shown to be superior in terms of overall response rate, and we have to give Eltrombopag from day one onwards. And This has shown in various studies that it causes early response also. Like if we were giving all the three agents at the start, it has been seen that the likelihood of early response is more when we add Eltrombopag to the horse ATG plus cyclosporin, and we give it at the dose of 150 mg per day. Empty stomach, we have to explain the patient that 2 hours before and 2 hours after taking the pill, patient has not to take any food intake. So compared to two agent immunosuppressive therapy, the triple anti immunosuppressive therapy is far superior if we compare to the two agents. So this surge, because it stimulates, it is so not only to stimulate platelet production, the use of Eltrombopag has also shown that if you use Eltrombopag, patient's hemoglobin level and WBC level also improves. So that is the reason behind giving triple immunosuppressive therapy to the aplastic anemia patient.
Any adverse reactions we have to monitor while we are giving Eltrombopag, specifically
So,
Patient
liver?
can, yeah, so patient may develop liver dysfunction. In that case, I usually either reduce the dose or temporarily stop the Eltrombopag.
gastric
Do you see?
intolerance. Gastric intolerance is frequently seen, and we usually ask them to take it in the early morning time, and preferably avoid taking tea or coffee. Sometimes we kind of want to have minimum 3 hours gap between that drug. And many patients, if they develop gastric intolerance, they have a self habit of taking pantoprazole also. So will tell that patient some kind of gastric tolerance, even if it is there, just accept it, and at least give 3 hours gap between the time of taking Eltrombopag and any other drug that you want to take.
Thank you. So when you give this Eltrombopag, if you clinically examine them and see their conjunctivitis yellow, but if you do their bilirubin is normal. Any experience?
Uh, yes, sir. This is the I mean I see it the other way around. Actually, I feel the jaundice to be clinically very subtle, but if I do the LFT, bilirubin will be somewhere around 4 to 5. And then when I reviewed the literature, it said the Eltrombopag metabolite can technically interfere with our bilirubin reading spectrometer. So some of the metabolites of Eltrombopag can technically interfere, and it can falsely give a supranormal value of bilirubin, is what the literature says. So that I have frequently encountered. But then again, unless if it is more than 5 times the upper limit of normal, I don't stop Eltrombopag. And sometimes I have used this traditional conventional GI measures like Udiliv or Glutahans to kind of as an hepatoprotective agent. I don't know how much level of evidence that is that, but it worked in some. In those it works, it works.
Okay, thank you. So let's discuss something about which is a very important problem or the adverse reaction related to Eltrombopag is the clonal evolution. So you have seen any patient evolving clonally to leukemia or something? So anybody has that experience? Anybody can speak on this topic.
Sir, I have had one ATG treated patient with Eltrombopag and cyclosporin, young male, who evolved into MDS with monosomy 7, and then he was taken up for a matched unrelated donor transplant. He did have mud donors to begin with, but at that time the standard recommendation was matched sibling donor, otherwise ATG. Now the guidelines have changed, so eventually he did undergo a transplant. So that is my one patient who did have a clonal evolution within 2 years.
How do you prevent
Baseline
this?
cytogenetics was normal.
How do you prevent this? Is there any schedule which can prevent this?
Not sure.
Actually, the protocol say if they have a PNH clone at baseline, we can monitor the PNH clone Q3 monthly. And but if they are on immunosuppression, if they had normal counts and suddenly if they drop their counts in between, then those patients are the ones where we can repeat a marrow to pick up early MDS. And to an addition of the marrow aspirate, we can perform an cytogenetics on cytogenetics and directed fish directed panel on that particular patient, and that is how we can actually maybe early detect clonal evolution. That is one thing. But otherwise, to prevent, I don't know we have some strategy or not.
There are recommendations. Basically, you can continue with Eltrombopag with ACE for 3 months, and if the patient has shown you good results, you can slow it down, or you can at least carry on till 6 months. But then you should not continue beyond 6 months. So that would probably reduce the clonal evolution.
So,
Any
I have a doubt. Maybe I can ask you
yes,
how
yes.
in some of in the MDS protocol per se, some of the low risk MDS patients we can give TPO agonists. Uh, how that literature is quite contradictory in MDS low risk when we are able to do TPO agonists, knowing that how sure we are that the theoretical risk of progression with TPO agonist is there. I
I
can find
think you
actually
have,
I can find contradicting evidences. I can find some papers telling it
yeah,
is
yeah.
clonally evolved, but some papers say it is safe. Even in Fanconies, now I came across a paper where we can do Eltrombopag for when they have isolated thrombocytopenia. We can do Eltrombopag. Is what the literature says. So I just want to take your inputs.
No, that's true. You have you can never say what has got what. So ideally, if we are using Eltrombopag, we use for 3 to 6 months, and beyond 6 months, we should in fact think about whether you really need it. So I think that would be important. Now there
Sir,
are
your
any other.
tapering protocol for Eltrombopag, so do you stop it with how to taper it?
You can slow it down, but most of the literature they say at 6 months, because most of the patients who have responded, they will continue to respond even at even if you stop it. Suppose you get 70, 80,000 platelet, you can stop at 6 months. That's what the literature says. So ACE therapy looks to be great. Now, are there, you still have 10, 20% patients who don't respond to all this treatment. So what do we do with that? All these 20% patients, and also there are some patients who have fever at presentation, they have pneumonia, and you cannot use this IST. So can we, in that situation, when they are infected, when they have pneumonia, when they have overwhelming infection, during that period, how do you manage these patients? How do you go forward to treat or cure these patients?
So usually at that point of time when they have an active infection, uh, uh, if it's an young patient with a good ready-made available donor, active infection and bleeding is an indication for transplant straight away. But it's not possible always at that point of time where we preclude also the use of ATD. So sometimes in elderly patients, with this scenario, I've only tried a doublet, and we kind of sit on infection, maybe use SOS granulocyte transfusions to tide over the infection. So eventually, over 21 to 28 days, the slightly ANC picks up. ANC and platelet counts picks up. So I think if you are able to contain the infection, doublet is also a way to go. But otherwise, active infection and bleeding are a straightforward indication to perform emergency aplastic transplant.
So great. So now this aplastic anemia. You have any other challenge while we treat these patients with the ACE therapy? Anybody had any challenge? Yeah, Dr. Vikas Goel.
Sir, cost issue is there, sir. Even some of the patient cannot afford thymogam. So this is one of the challenge we face in my practice.
That's right. So let's finish this. And I ask you one question. If the patient relapses after AT therapy, what do you do? After immunosuppression therapy, the patient has relapsed. He received horse ATG, and initially he received horse ATG and only cyclosporin. He got only two, and now he has relapsed after 4 years, 5 years. So what do you do now? What are the options, Dr. Gopinath?
Best thing is to, in this lab setting, the first option would be to consider a transplant, because all the other therapies are supposed to have all the other therapies have actually shown results which are not favorable. So best way to counsel is for a second transplant. Theoretically, rabbit ATG is one which is tried. Alemtuzumab is one which is tried. But I have had both these scenarios. With alemtuzumab, I have had worst experience with patient developing multiple recurrent mycobacterial
Infections.
infections. Yeah, so that is alemtuzumab is the worst poison that we can ever use. And second thing is rabbit ATG. I would say the results haven't that convincing. Given the possible way, I would actually counsel these patients for an allo transplant.
So fair enough. I think that's okay. Now, something about prophylaxis. Do you use any prophylaxis during the management of aplastic anemia?
Actually, the
Any
guidelines
prophylaxis?
dictate need not use no rule of
Mm.
Cetron. BGH guidelines clearly says asterisk mark on Cetron and Valsiclover, but in our practice, because since we have a lot of active constructions going on here, I use antifungal prophylaxis. I use Valsiclover. Cetron, I kind of keep it on hold till we have a stable count recovery.
So we try to avoid using these drugs. We only use during and post ATG till the ALC is above 1,000. But yes, antifungal is something that we also incorporate, especially for very severe aplastic anemia, where there is a very high risk of fungal infection, which will compromise even the transplant. But the dose of cyclosporin, then we have to be mindful of the drug interactions.
Actually, in the other way around, I will take it as an advantage of reducing the dose of
The
cyclosporin. Even
cost
at
comes down.
yeah, I actually take it as an advantage. So
I think
usually,
posaconazole is a boon in reducing the
who is a
cost of
boon
all
indeed
drugs
for that. Yeah. So at
in
the
our
lowest
setting.
dose we can. Yeah.
And posaconazole, we have many generics now. Earlier, we just had Noxafil.
Correct. Correct.
So thank you. Last question about the supportive care. So what kind of supportive care would you like to give them? And what should be the lower limit? I mean, what would be the target from where you will start giving them supportive care?
Patient in hospital, I use a target of hemoglobin 7, platelet of 10,000. Sometimes in younger patients, I've even lowered the threshold to 6.56 because they look clinically well preserved. But if it's a patient who's just residing nearby or some kind of vicinity, then I slightly maintain a higher threshold of platelet. I just don't want them, if they are just out of my radar, I kind of set a higher threshold, 20,000. I know I'm against guidelines, but I just slightly keep a higher threshold because our patients, they decide to come tonight, they will come tomorrow morning. So by the time they should not lose them to bleeding. So for those patients not inside our radar, I keep a slightly higher threshold of A. Hemoglobin still remains the same, platelet 20,000. In elderly patients, where I find even at a hemoglobin of 8, if they get compromised, if the cardiac status get compromised, there I keep a target of 8. Otherwise, 7 and 10 is a standard answer for
I
all
think in
patients.
older patients with hypertension and all, also a platelet, 20 makes you feel a little more
Comfortable.
comfortable.
What about leukodepletion and irradiated blood products?
So
What's
it
your
is a
choice?
universal policy, sir.
That's
All are
universal.
Previously, they were not
Access
available.
to such blood products, unfortunately, especially in the north and the periphery, is very, very poor. Safe blood is a challenge for a lot of peripheral areas, which is very important for aplastic anemia.
So, any other question we would like to discuss it out here? Time is running short. So, Dr. Vikas, Dr. Amit, Dr. Gopinathan, Dr. Nivedita, any question?
So
Just
I
put
have one
there
question,
the
one thought,
yes,
which I
yes.
always get confused about. So if we have a young patient with aplastic anemia whom we are planning to take up for transplant, the transplant is imminent but not immediate. They're arranging funds, pre-transplant workup is happening. We're waiting for the NGS report. For whatever reason, there is a lag period usually of 3 to 4 weeks. So, or maybe more if the funds are an issue. So, do we start cyclosporin and Eltrombopag? Because I
Yes.
always fear that theoretically, if it will stimulate the marrow, will it make increase the likelihood of graft rejection during the transplant? Will it change the picture, and will it change the effect of the intensity of our conditioning? So what are the thoughts on that, whether we should incorporate these drugs while waiting for the transplant, or we should just give supportive care and not put the patient, because liver kidney dysfunction will also happen with these drugs? What is the
See,
practice?
If it's not transplant, then we definitely give. We are planning for the immunomodulation. In that we give, but transplant, Dr. Gopinathan will say. He can discuss. Dr. Goel, Dr. Amit, any thoughts about it?
Because realistically, patient will need some time for
Yeah,
before proceeding to the
yeah.
transplant.
So actually, I have had patients where the same way, ma'am, but what you're telling, they take some time for arranging funds. But in that time, we are given only cyclosporin and Eltrombopag, just at least to have a reasonably transfusion independent interval. And we have taken these patients on the same flu-cy ATG protocol only. We haven't modified any conditioning at that point of time, and they have engrafted. I don't think those patients whom I remember, they haven't had primary graft rejection per se. But we have used this strategy because one thing is, if at all we keep them transfusion dependent, one is theoretically alloimmunization risk is there,
Again, that will make the
increase the risk
transplant
of
outcomes
rejection.
adverse. Yes.
Yeah, and iron overload, secondary iron
And you
overload is
will
a significant
need a higher dose of ATG also maybe in your conditioning, which will increase the
conditioning,
cost if there's transfusion burden is very high.
very high.
But I always wonder that whether there is some response, the marrow is getting more cellular. So will my
Okay.
graft get I always struggle with this, whether it's to start or maybe just, keep on supportive care. I just wanted to hear your thoughts on this.
At this point of time, I'm just keeping them. The first target would be maybe to expose them to lesser transfusions. Maybe that's my.
So when I was doing my residency, I was in a government hospital. There, the average time to transplant was 9 months for aplastic anemia. Funds used to come from RAN. So then everybody used to be on cyclosporin. But now in a private organization, it's going to be much shorter, the period to transplant. So I often wonder that, what's the best approach in this period? And any thoughts of on using the haplo conditioning for matched sibling donor, because data is coming up for that.
Haplo condition means a PTCY prophylaxis.
PTCY and incorporating the ATG flu-cy TBI conditioning, 4-gray TBI.
4-gray. At least till this point of time, I have not used PTCY in aplastics. I mean, for the matched sibling donor. So I mean, practically I can't comment on, but I have used PTCY for MSD in other settings, other leukemias and other settings. And I think I am able to taper immunosuppression much faster. Maybe around day 75, I could say.
I think maybe that's the way ahead.
So thank you. The time is over. I think we should stop now. And we had a very lively discussion. Thank you, Dr. Nivedita Dhingra, Dr. Amit, Dr. Gopinathan, Dr. Vikas Goel, for being here today evening and making us all aware how to have the best practice as far as aplastic anemia is concerned, where we can use 3 drugs as everybody is using. Thymogam is no worse than the Adgam, and all the nitty-gritties of aplastic anemia, how to give the drug, what are its complications, side effects, everything has been discussed. And now I thank you all and thank the Bharat Serum for giving this opportunity. I hand over the mic to Dr. Vaishnavi. Dr. Vaishnavi.
Thank you so much, sir.
Thank you.
Thank you.
I don't know where is Dr. Vaishnavi.
I think, sir,